There we go. So, we might have other people joining us. So we're just going to go ahead and get started since I said 1 o'clock. Okay, so this is a case of a client. Her name is Anna. And of course, this is fictitious. Okay. And we call this unfolding because we're taking our client from the very first prenatal visit, talking about her history and the things that we do during those first prenatal visits. And then we're going to slowly get into a couple problems that she has. Okay. So this is, and I know that your HESI is going to want you to know things about how to do assessments early, what is important about a client's medical history, obstetric history, family history that affects her pregnancy, and what risk we are seeing, ideas that we might think, oh, she's going to be a high risk. Okay, so this is Anna. She's 19 years old. She doesn't have any allergies. She is Hispanic. She's bilingual, single. She does work part-time cleaning houses. And she comes to the prenatal clinic because she thinks she's pregnant. All right. So what we do, we're gonna just go ahead and get her height and her weight, and we'll get her vital signs, and talk to her about her family history and obstetric history. So let's do a little of this, okay? So I went ahead and calculated the BMI. Sometimes I spend time with students helping them how to calculate the BMI. And I put that formula at the bottom of the screen. There's 2 different formulas that you can use to calculate the BMI. Okay, so she is 31.6. Now, what is a normal BMI? Do you remember the normal?
I don't. I know less than 30 is not. I know over 30 is obese.
Okay, over 30 is obese. You're correct. Okay. Do you remember what the normal BMI is?
No, ma'am.
Okay, that's something you definitely need to know. So 18.5 to 24.99 is a normal BMI, a normal weight BMI.
Okay, got it.
Okay, so anything less than 18.5 means that the client's underweight. Okay, 25 to 29.99 is overweight.
25 to
and then 30 and up is obese.
Okay.
Okay, so that is something you definitely need to know. You'll probably need to know it for the HESI. If not, you will need to know it for the NCLEX. Okay, so back on this first page, we identify her as a prima gravida. So what does that mean?
It's her first pregnancy.
Okay, so then what would her GP status be? Her gravidity parity status. So the G is how many times she's been pregnant, right?
Yes, I was writing it out. Sorry.
Okay.
Yes. Is it 11000?
Oops, I don't know how that got down there. I'm a very sensitive. So the P would be, 0000. Exactly. She has not had a pregnancy ever before. Okay. So she can't have any parities. Okay.
Right.
And I'm just letting you know her last menstrual period was January 6th of this year. Okay. And her gestational age is 9 weeks and 5 days. Now, let's talk about when she's due, because she wants to know when her baby's due. Okay, so Nagel's rule. Do you remember Nagel's rule?
We add a year and subtract 7 days.
We add a year, so it'll probably be this year since her
No, you
last period.
Subtract 3 months and add 7 days. Sorry.
Okay, subtract 3 months. So what is that?
December, November, October.
Okay, so October. What day?
I am adding the 7 days. It was the 6th, so 7, 8, 9, 10, 12, 13, 13,
Okay. Okay. And then what year would that be?
24. We add a year, right?
If it's this early in the year, no.
No, it's
About a year
23.
from her last menstrual period, which was in um January. So no,
Okay, so
not it's in
23.
it's this year. Yeah. Yeah. That's kind of tricky. You have to think about that. Okay, so estimated delivery date would be October 13th. Okay,
Okay.
so we do that and then she can make her plans. So if she's 9 weeks and 5 days, is there any information at all? I mean, are we going to be able to feel, palpate a uterus at all at 9 weeks and 5 days?
No, ma'am.
No, maybe. Can we hear fetal heart tones?
Mm, yes.
Yeah, yeah, we could. I've heard them as early as 9 weeks, and I believe that's what your text says. Okay, yeah, we've heard them that early, and it's exciting because they're coming in with their first pregnancy. It's exciting. So she thinks she's pregnant. So what is she experiencing? What's her perspective? We're presuming she's pregnant when she tells us she thinks she's pregnant. So what
Right.
could she be experiencing?
Probably a missed cycle or positive at-home pregnancy test.
Okay, amenorrhea. So get used to the terms. Um, a a pregnancy test is
That's a
not a
probable.
presumptive. Yeah, it's probable. Yeah, because it is an objective test. Okay, so
Um,
okay, what other things might she be feeling?
Probably some tenderness in her breast, soreness,
Okay,
nausea.
how about fatigue?
Yes, that first trimester fatigue.
Yeah, urinary frequency
That's what it
sometimes.
says.
Yeah, yeah, yeah. Those are the important ones. Okay, other than our positive pregnancy test, and we usually redo it in the office. Or we might opt to do a blood work, do a blood test to identify it.
Yes.
Okay, what else might we see? Might you see if you're the nurse and you're doing a physical assessment? What might you see that you think, oh yeah, you probably are pregnant?
Uh, would she have like enlarged breasts? Um, maybe oh my gosh, those signs. The good one sign, the good L.
Okay, so yeah,
Yes, ma'am.
good else, Chadwick. So what's the Chadwick sign?
Oh my gosh. What's that one? The discoloration of the cervix.
Okay. Yeah, it's a bluish tint. It's not really discoloration. It's a blue tint. Okay.
Okay.
All right. So that's good. And sometimes we look at Braxton Hicks as if they have them that early. Okay. Another sign up here is going to be quickening.
Okay.
My
Quickening is a
computer's
presumptive.
lagging a little.
I didn't know that. So quickening is
Yeah, quickening
presumptive.
is what you remember what quickening is?
No,
Okay.
I can look it up.
So quickening is
I've heard it and I've tested on it.
when she feels the baby
Oh
moving.
yes, the moving. I get that
Yeah,
confused
yeah,
with lightning. I missed it on my test. I don't know why I
yeah,
get those mixed up.
yeah. I always think of lightning and try to teach it as it drops down out of the sky, so the baby's dropping.
Oh, that's smart. That makes sense.
Yeah, yeah. I didn't spell Braxton Hicks right. It's really X, but that's okay. Okay, all right. So we also might be able to palpate that the uterus is larger. That's a probable sign too. So how can you tell your client that she's pregnant for sure?
The ultrasound,
Okay,
listening to
yeah.
the baby heart rate.
So if we hear fetal heart tones on that first visit, then we can tell her she's pregnant. Yeah.
Yes. Or the
Okay.
yeah, I said ultrasound, send the baby on the monitor.
And the ultrasound, if we do an ultrasound. So when would you do an ultrasound on that first visit? We don't normally do it on the first visit because if we're doing a physical exam, insurance is not going to pay for it. So we just have them come back maybe the next day and just do the ultrasound. When else would you do an ultrasound?
On the first visit?
On the first or second visit, why would we be doing an ultrasound on any client?
To make sure the baby's in the right area. Make sure it's
Okay.
not a um
Okay,
make
not
sure it's not in
ectopic.
her tubes. Yes, ma'am.
What other,
Um,
can you think of some other reasons we would want to do an ultrasound?
to verify the age of the fetus.
Okay, to date the pregnancy. Yeah, good.
See if she has multiple in there.
Okay, multi-fetal pregnancy.
That's all I can think of.
Okay. Well, if she's bleeding, we might want to do it. Okay. If she has an abnormal history of an abnormal uterine anatomy, so we want to look at her anatomy.
Oh, okay.
Uh-huh. Yep. Sometimes if there's a history of congenital defects, it's not that we can see them, but we want to look to see if the pregnancy is normal. I mean,
Okay.
does it gestational sac, it depends how far along she is. So sometimes some abnormalities we want to look at. Sometimes if our client is obese and we just can't hear a heartbeat at 14 weeks, when we should be hearing a heartbeat, we need to do an ultrasound. So there's a
Okay.
lot of different reasons for doing an ultrasound. And during this time, we also can identify a cervix that's too short. Okay, if we have a cervix that is incompetent or insufficient, if it's too short, we might plan to do the cerclage. And usually we diagnose those things early in the pregnancy so that we can make plans. Okay. All right. So we're going to talk about her past medical history because it's very important to know what's surrounding her, right? So she does have a history of some mild depression. She lost her younger sister to meningitis, so she's just still struggling with that a little bit.
Okay.
So, but her gynecological history is pretty much uneventful. This is just her first pregnancy. She's 19. Okay. So she had her first period at age 11. She's never had a pap test. She's not 21 yet, so she hasn't needed one. Okay.
Okay.
She only has one sexual partner, and that's her boyfriend, who is the father of her baby. Okay. So right now, so far, do you see any risk factors? When we look back,
I see the weight.
the weight.
And I see the depression.
Okay. Okay. Weight and depression so far. Yeah. And in age, she's only 19.
And age.
Not
Yes.
not technically an adolescent, but pretty close to one. Okay. Okay, so she is having a little bit of nausea occasionally, not too bad. So she tries to take her prenatal vitamins. And prenatal vitamins, if they're labeled as prenatal vitamins, they do have the folic acid that she needs. Okay. Okay, so we're not too concerned about that because she's trying. No drug use, no illicit drugs, no prescriptions, no smoking, no nicotine, no alcohol consumption. So that's all good. Okay. Family history, however, is a little concerning. So her father has high blood pressure. Her mother is a diabetic. Her sister had a baby, and during that second pregnancy, she had preeclampsia. So this is her sister. So that increases Anna's risk for preeclampsia. Okay. And then, of course, she lost her younger sister. And then she does have a brother with substance use disorder. And then she has another brother that's alive and well. So there's more stuff here now. So risk factors, family history, high blood pressure,
Definitely.
diabetes, preeclampsia, substance abuse can affect the pregnancy if she is exposed somehow. Okay, so this is social history. So what's going on? You can read that. And you should pick up some more risk factors here.
They have a lot of people in that house.
Yes, they do. Uh-huh.
So the smoking when the brother comes over is definitely
Yeah,
a
so
risk factor.
little secondhand smoke there, yes.
Yeah, the illegal substances, I know she's not taking it, but she's around it and it's causing her to be stressed, what could cause her
Yeah,
her blood pressure to go up.
yeah, could be, yeah. Mm-hmm.
So she's pretty much gonna be doing the pregnancy, kind of sounds like by herself. Support system also can be an issue with her blood pressure because the father works all the time.
Yeah, yeah. So he's trying. So there's some financial concerns there. Yeah. She probably has a lot of family support for mom and dad. It doesn't really say anything in there. It'd be something we would want to ask her if she felt like she had the family support she needed. And certainly we want to, if she doesn't have enough financial resources, we certainly want to direct her where she can maybe perhaps get some help. Like if she doesn't have any insurance, we can send her to the health department to get some temporary insurance that the government provides. And then certainly we do want to see where she is as far as depression. So using a tool like the PHQ-9 tool, it's just a tool we use to see how depressed she really is. It's just a tool. We get her to fill it out, and then we can refer back to that as she goes through her pregnancy and postpartum. And screening for any, asking her if she's safe at home. Has anybody ever hurt her or anything like that? So we need to get this information so that we can ensure, or at least provide for her the safest and the healthiest pregnancy possible.
Okay.
So we've already identified a lot of the risk factors. Okay, so this is her first visit. Okay, we've done her history. Her vital signs are as such. Blood pressure looks fine. Heart rate is normal. She weighs 178 now. Okay, and we got her BMI. We're going to check her urine, and we're going to check her urine every time she comes in for a visit. So for the first 28 weeks of pregnancy, she's going to come in every 4 weeks minimum. Okay. And every time she comes in, we want to check her urine, her weight, her blood pressure, just to make sure things are going well. So what is an abnormal protein on a urine dipstick? What do you not want it to be higher than? It's like a 1+, 2+, 3+.
On the dipstick.
Yeah. And in her situation, there's no protein. Okay. Usually if it's 2+, then we need to do some investigating. It would mean that the kidneys are suffering, or they're being stressed somehow. Okay. And it's an early sign of preeclampsia. Okay. So we always check the urine, the protein. We check for blood, with the dipstick, nitrites, and then of course glucose. Okay. So so initially we want to culture the urine. Okay. And we also going to do a urine drug screen. And the urine drug screen, we have to get her permission. We have to let her know that we're going to do it. It's pretty much standard of care. So it's an opportunity to talk to her, even though she denies using any drugs. We certainly want to validate that. She can refuse it, absolutely, and we can't do it if she doesn't give permission. But if her brother is maybe using cannabis or some other smokable drug, then it might be in her system a little bit too. So that would be some concern for us.
Oh,
Okay.
okay.
Yeah. So, and then we want to draw some labs. We're going to check thyroid functioning, a CBC, platelets, her blood type, if she has any antibodies, any blood antibodies, HIV status, hepatitis B, HCV, RPR, and then titers to vaccine viruses like rubella and varicella. We want to make sure she's immune to them. Okay, so when people get an MMR, that's their rubella and that's their varicella. Well, that's not their varicella, but in time, sometimes those titers drop and we lose a little bit of our immunity. So we're kind of seeing that with measles nowadays. Okay, so we do
Oh,
want to get a titer. So if she's not immune, then we have to educate her, avoid people with rashes. Okay, be careful about being in crowds. And then we're going to give her a booster after she delivers her baby.
okay. That's exactly what I was about to double check.
Yeah, we can't give her a vaccine during the pregnancy. It's a live vaccine and it would damage the baby's heart or the eyes, something like that.
Okay.
So another thing we can do that first prenatal visit is carrier screening. Okay. So in our family history, it didn't say anything about any genetic diseases or genetic disorders like cystic fibrosis, sickle cell, and she is Hispanic. So darker skinned people, we do want to verify sickle cell as well. Okay. And there's some other things. They're starting to routinely test for, it's called skeletal muscle atrophy. It's a genetic disorder. And sometimes we'll do that. Okay. And PKU, we can check for all those things. And that's our carrier screening. Is our client carrying a gene for any of those disorders? That way, then we can determine, is her husband carrying the same gene or her boyfriend carrying the same gene? So that we would know if what the baby's risk is for that disease. So remember, sickle cell and cystic fibrosis and PKU are all autosomal recessive diseases. So that mother and father have to be carrying that gene. And then the baby that she will deliver has a 1 in 4 chance of having the disease, a 50% chance of carrying the gene, but not having the disease. Okay. So that's your autosomal recessive.
Okay. And that was sickle cell and cystic fibrosis.
Yeah. And PKU.
And PKU.
Yeah.
Got it.
Can you see the screen?
Yes, ma'am. I was writing it down. I
Okay.
was just double checking.
Okay. So we got that first visit in. Oh, no, we have to do our physical exam. Okay. So we did all the testing and we've gotten the history. Now we need to do a physical exam. So we do want to check the thyroid. Okay. We can do a breast exam as clinicians. And then at that time, we can teach about her examining her own breast and when she would do that when she's not pregnant. So in the middle of her cycle, before actually it's best to wait till after the period, about a week after her period ends is the best time for her to do a self breast exam when the breasts are not tender or swollen. Okay. We want to listen to her heart and her lungs. She didn't say that she had asthma or anything, but she might have forgotten. So as we listened to her lungs, we could find that out. Extremity, just a brief extremity, and then abdomen exam, auscultate, palpate. We should be able to palpate the fundus which week?
11. No, it's too early at week 11. Is it 16?
Which is
12 or
9
16?
weeks. When does the uterus begin to rise above the pubic symphysis, the pubic bone, when you can begin to palpate it in that lower pelvis? Do you remember?
Is it during the second trimester or the too
It's
late?
it's it's right at the end of the first trimester, so
Okay,
12
so
weeks.
12 weeks. Yes.
12 weeks.
I
Yeah,
was thinking
12
12 to
weeks.
16, and I was like, well, I feel like 16 was kind of late.
Yeah, so 12 weeks, we should be able to palpate the top of the uterus. Okay. So we do that, and of course she's only 9 weeks and 5 days, so we're not feeling anything. But then we can put our Doppler and hear the heartbeat. Okay. And then we're going to do an actual bimanual exam. That means I've got 2 hands. Okay, bimanual. So I'm going to check her cervix. Is it soft? Then I'm going to palpate her uterus with my hand that's on the outside, check for any masses or anything, make sure the cervix is easily moves around. And if she's farther along, I can feel the top of the fundus, okay, on the outside. And then our speculum is going to show us the cervix. Okay, so we can then see the Chadwick sign. We can also see the bluish tint to the vagina. Okay. So at this time, she's only 19. She doesn't need a PAP. Okay. And I never liked doing PAPs during pregnancy because I don't think the result is accurate all the time. So it's okay to wait till after the pregnancy. So, but we do
Okay.
need to do some cultures. We just need to make sure she doesn't have any chlamydia, gonorrhea, or anything like that.
Okay.
Okay. So
Yes,
that's our first visit. So usually 4 weeks later, they come back. So this one is off a little bit. It's 15 weeks already, so we skipped a visit. But
okay.
that's okay. It's just because the timing is off, but I don't want. Okay, so we're just going to say at 15 weeks, we're seeing her again here. And we're making sure we're going over all her lab results that we drew from the previous week. Okay, so she's blood type A positive. Do we need to worry about Rogan?
Yes. No.
No,
Negative. We do not.
no,
Jesus.
no. We don't have to worry about it. She's positive. She has the antigen, the D antigen on her red blood cells, so she's good. We're not worried about anything. Okay, and we did do the carrier screening. It was negative for everything, including cystic fibrosis, sickle cell. Okay, so all was well. All right, her blood pressure 136/80. Now she's gained how much? She's gained 4 pounds since so she hasn't gained much since 9 weeks at all. Okay, so if you notice your client not gaining much weight, how much weight do we like to see them gain beginning the second trimester? Do you remember?
It's 1 pound a month in the first trimester.
It's 1 to 4 pounds for the first trimester. Yes.
Okay.
What do we kind of recommend after that?
Oh, I don't remember.
Okay, 1 to 2 pounds a week.
1 to
So 1 to 2 pounds a week they can actually put on. Okay, closer to the 1 mark. It depends. So let's say you have a client and they're not putting on much weight. What do you think would be some good nursing interventions?
I can ask her like, what is she eating? How's her diet? How's her appetite? First to start off.
Yeah, that's excellent. Excellent. We want to know what they're eating. and how often. So just let them talk to you about what what they've been eating the last 24 hours. Okay. Okay. So we are going to check her urine again this time. Listen to the baby's heart tones. Fundal height, but she's only 15 weeks. We're going to palpate it, but we typically don't measure it at 15 weeks, but we certainly want to palpate. Okay. And she should be below the umbilicus. Okay. And then we did an AFP test. We did that last week. Okay. So the AFP test, also called one of the markers in the mother's blood. Okay. The AFP marker. Okay. And we know that AFP will tell us a lot of information. So if the AFP level is low in her blood, it usually signifies a risk for Down syndrome. Okay, so remember, down low.
Okay, so if it's low Down syndrome.
Down
What about her
low.
HCG being low? Is that
Well, the HCG for Downs is usually a little higher.
okay?
Okay. And then neural tube defect, if her AFP is high. Okay, and then you might see a low HCG with that.
Okay.
So that's the difference. And that gives us some information to start with. It's not diagnostic and it's not super sensitive. So there are some other things we can do at 15 weeks if the AFP level is not normal. Do you know one thing we can do? There's two things that we can do.
No, I'm good. No, I don't.
Okay, that's all right. So one is we're going to start with an ultrasound to see if there's anything obvious on the ultrasound that indicates Down syndrome or neural tube defects. And you
Okay.
don't have to know those details. And it's still early in the pregnancy at 15 weeks. It's still so early, but we do want to do a brief ultrasound. Okay. What you might see in Down syndrome at this point, the humeral length, the length of the arm bone is shorter than normal, shorter than what we would expect. Okay.
Okay.
Or the length of so the length of the bones might not be as long as what we would expect. And also an absent nasal bone. Okay. All right.
Okay.
So those are some things. Yeah. And then for the neural tube defect, the nuchal translucency might be off. Okay. So she's at 15 weeks. She's having some low back pain. What are some good things for her to do? What would you help her with?
She's having low, maybe so get a heating pad to help with the low back pain.
We usually don't recommend heating pads, hot tubs, or anything like that in pregnancy.
Okay. Much. So it's not anything of concerning. It's just like when is she
Not
having the back
usually at
pain?
not at 15 weeks. Yeah. But
Is she
you
having it when
certainly
she's moving? Is she having it when she's standing all the time?
good. Yeah. Yeah. So ask her more information. It could be, I mean, it's early to be in preterm labor. It'd be more of an abortion at this point, spontaneous
Right.
abortion. So you want to certainly make sure she's not bleeding. Okay. Okay. Or having any cramping, pelvic pain. If it's just her back, I have sent my clients with back problems early in pregnancy to physical therapy. There are women's health physical therapists, and that's what they do, just women's health, the physical therapist, and they know how to help. They'll teach them stretching exercises, pelvic rocking, things like that to help them, and just you can have a massage during pregnancy. It's very limited.
Okay.
Sometimes we'll have the client lay on their side and we can rub those muscles, massage them. So, okay, so she's going to come back, and this says 4 weeks. So we usually see every 4 weeks. And so the next appointment is going to be for an anatomy ultrasound. So every client, no matter what, gets an ultrasound around 20 weeks. It's called the anatomical ultrasound. And it's just a very gross ultrasound. We're just getting, are the feet there? Are the hands there? Does a heart look like it's functioning fine? Any obvious abnormalities? So we do that. It usually takes about an hour. We do measurements. We measure the size of the head, measure the chest, or the machine does, okay?
Okay.
So her AFP levels are normal. That's good news. She's up to 188 now. So she's putting on some weight. Her fundal height is 21. So we're measuring it. Okay. So where would you expect the fundus to be at 20 weeks?
Where or the height? Like, because she's 21, which is still normal, but it's like 1 centimeter more than what she should be. So what?
Yeah, it's still good. It's still good. So
Oh,
it's
so you
going to
mean
be
like
right
just where
there.
is it on the body?
Yeah. So
Oh, at the
yeah,
belly button.
yeah. So right around the belly button at 20 weeks. It's kind of what so we hear a good fetal heart tone, but we're also doing the anatomy. So everything was fine. We're talking to her about her nutrition still and encouraging her to do some walking, some kind of atraumatic type um, exercising, and then coming back early. See, we're going to do a glucose tolerance test for her a little bit early. Do you know why?
Family history, or because she's obese?
Both.
Okay.
Excellent. Yeah, both. So we want to catch it if it's going to occur. Okay. It would be interesting to know if her mother had gestational diabetes before she was diagnosed with type 2. That's a very common pattern among, my Hispanic clients I saw. They have gestational diabetes and then they become a diabetic.
Mm.
Okay, so she's at week 24 and we're doing the glucose tolerance test. So usually they come into the office fasting. We have them drink some 50 grams of sugar, glucose in a fruity drink, and then we draw their blood in an hour. So her 1 hour was a little high, okay? She had a little bit of glucose in her urine too. She's put on some weight. She's at 194 now. So she started out at 178. So she's almost put on 20 pounds. Okay. Blood pressure is still kind of in, we got to keep an eye on that blood pressure too. Okay. So we're going to go ahead and check her urine. We already did that. Fundal heart, listen to the heartbeat, and she's going to come back because her glucose tolerance was too high. We usually don't want it much above 135. Hers is at 148. So she's going to come back and we're going to do a 3-hour test. And you don't have to know this. You don't have to know about the 3-hour test. But when we do a 3-hour test, we do a fasting 1 hour check, 2-hour check. So we're giving them a 75-gram glucose load. And then we're checking 3 hours out. Okay. So her 1 hour, once again, was 148. Okay. So it's a little high. Okay. We did go ahead and diagnose her with gestational diabetes. Okay. So what is important for the nurse to be aware of at this point with gestational diabetes? What do you think you need to be? Or what are some of your interventions?
Oh, probably like a nutritionist. Let's figure out the diet. Let's talk about her maybe insulin. Does she get insulin to help control that? Making sure she's not gaining any, holding on to like too much fluid or anything.
Okay. So we educate, right? We have to educate her. And so we have to give her a tool. We have to help her see what's going on with her body. So we're going to get her a glucometer. Okay, everything she needs to test her own blood at home. So we're going to have her test several times during the day. You know, when she gets up in the morning, before a meal, and after a meal. And we're going to tell her what the target is. We want it to be less, we don't want it to be much above 90 when she wakes up in the morning. Okay. And then hour after she eats, we want it to be less than 140. Okay, we want it to be less than 140 after she eats, 1 hour. And then 2 hours, we want it less than 120. So she's going to keep track of what she's eating, when, what her sugars are, so that she's going to come to the office and we're going to review what she's eating. If we see spikes of glucose levels, then we can adjust what she's eating. There's a lot as nurses you can do. We don't necessarily have to send them to a nutritionist, okay? Because we can help them. We know as nurses what good nutrition is, okay? And if we begin to see that she's not controlling, then we might have to begin some medication. A lot of patients are able to control with just diet and exercise. Okay. All right. So now she's 28 weeks. Blood pressure's high. Okay. She's at 200 pounds. So she's gained what? She was 178. So 20 pounds, 30 pounds. So she's still okay, but it's a little on the high end. Okay. So she still has a little glucose in her urine. So we're going to go over her glucose log and see what's been going on. She's having some postprandial hyperglycemia. In other words, after she eats, it's staying high. So yeah, so we need to start some medication for her. Okay. So we're going to have her come in more often. Okay. So glyburide is a good medication for pregnancy. So we're just going to have her take this dose once a day. And we might have her come in a week to see how she's doing. So we also have to teach her what it feels like to be hypoglycemic. We need to teach her signs and symptoms of hypo and hyperglycemia. So there's a lot of education that goes on with a diabetic. Okay. So at 30 weeks, she comes in. Now she's got some protein in her urine. We're doing an ultrasound with gestational diabetes. Remember, with any kind of hyperglycemia, what occurs with the fetus?
Hyperglycemia? They are larger.
They get big, yeah. And the amniotic fluid is higher. It continues to grow too. So polyhydramnios with our diabetics, okay? But hers is normal. Her amniotic fluid is good. Okay. Baby is at the 75th percentile, so a good sized baby, okay? So she's doing well with her glyburide, okay? So this is a client at 30 weeks. This is when we talk about fetal surveillance, okay? We've got a high-risk client with diabetes. So at week 30, we're going to keep a closer eye on her, okay? We're going to watch her sugar. We're going to watch her baby's growth. Check that amniotic fluid, okay? So she's going to come back in 2 weeks. It says 4 weeks, but we would really have her come back in 2 weeks. I've made some changes to this. So have her come back in 2 weeks, and we're going to do an ultrasound and look for growth and look at her fluid, okay? What are some other ways that we can survey during that third trimester, other than doing an ultrasound? Do you remember other ways of surveying? What other information do we want to know?
I'm not sure.
Okay, so let's say she came in, so she came in at week 32. Let's say week 32, we did an ultrasound and baby's pretty good size. We might do an NST, non-stress test, and a BPP, just to see how baby is faring. Okay, so ultrasound for growth, BPP, non-stress test. to make sure baby is thriving and is still having really good oxygenation. Okay. All right. So the next slide. So she's now showing signs of preeclampsia. Okay, her blood pressure's up. She's got some protein in her urine. And what some other things that she might be experiencing if she's got some preeclampsia going on?
The swelling, the edema, like I said, her blood pressure is high. She could be having some headaches. She's definitely short of.
Now, edema in the hands and the face is not supported by evidence. You hear it, your textbook talks about it, but it's not evidence-based. Okay. Pulmonary edema, yes. Okay. But headaches, visual changes. Okay.
Okay.
All right. So she has a headache, which is down below. You didn't see that. She came in early to her appointment because she has a headache. And when they checked her blood pressure, it was high, protein in her urine. And so they diagnosed her with preeclampsia. So we're going to let her go home, but we want her to watch her blood pressure. And if her headaches continue, she needs to call us. Okay. What else would you want to do during this visit? When you diagnose, what other things would you want to check besides the protein?
We're diagnosed with preeclampsia.
Yeah, what would you want to check? But sometimes we can tell the severity of the preeclampsia by doing some lab work. Okay.
Oh, yes.
So what labs would you want? Do you remember?
We're going to, like a CBC.
Okay. And what's in the CBC that you're wanting to see?
The creatinine level.
That's not going to be in your CBC.
We checked in. Oh my God, I'm trying to think so quick.
Okay.
I'm not sure.
Okay, within the CBC, there's not only the heat H&H, but there's also platelet level.
Okay, yes.
So it would give us a
that's
platelet.
affected by
Yeah,
that?
definitely.
Okay.
We need to know that because that's what, liver?
Okay.
Okay, so what other labs would you want? This is where you have to think about, okay, now what organs are affected by preeclampsia? What can I know?
I don't know.
Okay, that's all right. So the chemistry, so like AST and ALT, which is the liver.
Right.
Okay. So if her enzymes are elevated, then we might have to hospitalize her, or if her platelets are low, which tells us that the preeclampsia is farther along. In other words, it's occurring and we need to intervene. Okay. If her labs are normal, then we would let her go home. Okay.
Okay.
As long as she understands that she needs to let us know if her blood pressure gets high or her headache persists or she starts seeing signs, has any pain. Okay. All right. I think we end up putting her in the hospital, and that's the end of my slides. She came to the ER. So she didn't even call the office. She actually came to the emergency room because she was feeling so bad. And her blood pressure was up and she was hurting. Okay. So then what we would do is go into the hospital. The rest of this scenario, we would be in the hospital managing her preeclampsia. So what drug would we be using?
Magnesium?
Yeah, magnesium. Karen's here. Yay! Yeah, yeah,
I was
yeah. So
answering some of the questions too.
when did you jump on, Karen?
From 1 minute to 2.
Oh, okay. So you just got the last little bit of
Yeah,
it. Good,
yeah,
good, good.
yeah.
Okay. All right. So in class today, I have class at 3, and we're gonna work on some whiteboards, and we're gonna go through some scenarios and work on that. Okay. So I'm gonna stop this recording, and so I can just stop it.